what are the implications then when we drill down on this for primary care and millions of folks for managed care? Who's going to pay for this? And is this disease even on your radar?
It's not, I don't think, really on the radar, if you will. It's not one of the high,
All right, well, I'm just going to stop you.
Okay.
Because you know where I'm going, which is these guys just told me this is the most common cause of blindness in this age group, all comers, and it's not on your radar. Why not?
Well, because we have the entire patient to be concerned about, and other disease states occur in much greater frequency, are much more costly, and in terms of being on the radar, I presumed you meant, is this at the top of the list of things that we need to take steps to address? I don't know, you can ask Peter if there's a different approach in his area, but I don't think this is something that I hear talked about very often.
So just out of serendipity, we do have medical policy around the treatments, the various treatment options, to make sure that the right people are getting the right medications for treatment of wet AMD. So the fact that we do have medical policy means it has definitely gotten our attention. And we do want to make sure that the right people are getting the right medication. And likewise, the people who don't qualify for the medication do not get treatment which is not needed for them.
Well, we're going to go on to medication in a minute.
Okay.
But let's take a look at the global problem, because
Sure.
you alluded to it. There's
Sure.
a whole patient out there that you've got to effectively bankroll in terms of medical care.
Sure.
And yet, if you lose your sight, a lot of that affects everything, as that we heard earlier.
Absolutely, and that's why we do not put barriers in front of patients to have preventive care. You're talking about the annual eye exam, totally covered, I would say, virtually by every health plan. And so in terms of prevention and detection, I think we've removed any barriers to having that done. The cost implications you asked about, short term, if somebody does have the diagnosis, there will be pharmacologic expenses, and long term, it's not just the disease itself, but the other attendant issues, the falls, the other things that come along with poor vision.
That's what I was getting at,
Yeah.
right? If it's not on your radar because you've got all these other, for lack of a better phrase, organ systems to worry about, yet if somebody loses vision, all these other organ systems are on the chopping block. They're all at risk here. So in the clinician's view, are these guys short-sighted, or are they about right?
I think the one very specific, that may not be relevant to either of your plans, issue that we've come up with this is a few of the plans that we're involved with, they only provide a few visits for a given provider. For example, if we have a new diagnosis of wet AMD, they'll only cover 4 or 5 visits in the next year. There's only a certain duration of follow-up that's allowed before a new diagnosis is needed. We've run into that challenge. It's a very specific issue, but that is a challenge if you're asking.
But this is a lifelong issue.
It is. This is a chronic problem that these patients need repeated visits for, often a dozen visits a year to treat by a single practitioner.
Yeah, and that will, of course, vary with plans. Many plans have no restrictions of that type. There may be some, though.
And just out of curiosity, is there an appeal process if you hit that barrier of you have 5 visits for a 12-month period of time? Are you successful, or is there information that you can share with others about how to best overcome those barriers?
So unfortunately, it takes multiple employees on our part, full-time employees, to deal with all the challenges that we need to undertake. But yes, it is possible to overcome these challenges.
But this is a complaint I hear all the time, and it doesn't matter the disease state. The one complaint I hear from clinicians over and over again is, we want to take care of patients, and I've got staff that's doing nothing but sitting on the phone dealing with payers. And what does that contribute to my practice? What does that contribute to his practice?
I suspect not as much as what one would hope it would. From a payer standpoint, we're trying to be fiduciary agents for the people that are paying for the premiums, and that may be a large employer, it may be Medicare, so government programs, and so we need to figure out a way to better deal with these issues of potential overuse, potential misuse of a particular product, which is in this case not inexpensive.